Hello, my name is Leslie Law, and this is my risk assessment project. My patient is a 31-year-old female Asian American. Occupation is a surgical operating room nurse, and chief complaint is halitosis. She has an ASA2 due to seasonal allergies and pet dander. Currently have a implanted contraceptive, no systemic diseases, no family illnesses, no surgeries or hospitalizations. Currently 5'8", weight of 180 pounds, and BMI is 27.4. Baseline vitals are listed below. Extraoral findings are all within normal limits. However, intraoral findings, patient has a class 1 occlusion, overbite and overjet of 1 to 2 millimeters. The following were found: crossbite, edge-to-edge bite, Kray's lines, deep posterior pits and fissures, generalized visible biofilm accumulation interproximally, and visible supragingival calculus. Clinical measurements of probing is 2 to 3 millimeter pockets with a 4 millimeter pocket depth on tooth 14 distal, BOP of 19.6%, no recession, no frication, no mobility, DMFT score of 0 all across the board, cal of 1 to 2 millimeters, marginal bleeding of 22.3. Plaque index is 64.2 plaque index and 35.8 plaque-free index. Plaque accumulated mainly interproximal as well as palatal and lingual. Gingival description, the only one needing to note is the maxillary free, scallop, severe generalized rolled borders on the anterior palatal margin, short and blunted contour on the facial aspect of teeth 8 and 9, localized mild inflammation on palatal gingival margin of posterior teeth, as well as the mandibular free, scalloped rolled borders on the buccal gingival margin, generalized moderate erythema found on posterior lingual margins. For radiographic assessment, slight generalized horizontal bone loss in the premolars, vertical bone loss on the following teeth, no carious lesions, calculus, mesial interproximals on the following teeth, periodontal ligament funneling due to subgingival calculus, lamina dura widening on the following teeth, and the crown to root ratio of 1 to 2. Patient has an AAP classification of generalized biofilm induced gingivitis with localized stage 2 periodontitis in the premolars, and the Westaway calculus code of 3 light medium, subgingival 50% calculus interproximal. The rationales are listed below. Nutritional findings: patient is a low caries risk, however, does have deep posterior pits and fissures and does not drink fluoridated water. Patient should limit snacking, as well as rinse and brush in between snacks and meals. And if they do have to snack, we recommend rinsing or chewing xylitol gum, as well as including more calcium and vitamin C into their diet. A patient was taught for OHI the C-shaped flossing method because they were currently doing seesaw method, as well as the modified Bass technique with a 45-degree angle targeted at the gingival margin, seeing as the patient's biofilm collects in these areas seen in the plaque index evaluation. Patient was also recommended to rinse with fluoridated mouth rinse to protect against dental decay, caries, and strengthen patient's teeth. Treatment plan is as follows. First 2 appointments were designated to do a full mouth assessment, as well as intraoral photos, plaque index, complete Canberra assessment, and OHI education with the patient. Third appointment was beginning of prophylaxis treatment of the upper right and lower right quadrants and reinforcement of OHI. Fourth appointment is prophylaxis treatment on the upper left and lower left quadrants, reinforcement of OHI. And the last appointment was a full mouth reevaluation with 2 sets of intraoral photos taken, plaque index, selective polishing, sealants, and fluoride application. Again, reinforcement of OHI, and assessing all findings with patient. Evaluation assessments: pocket depth for tooth number 14 actually decreased from 4 millimeters to 3 millimeters. Bleeding on probing percentage was 19.6, reduced down to 9.8. Marginal gingival bleeding was 22.3 and 0% at the reevaluation appointment. Plaque, interdental plaque was seen as yellow staining, which was reduced. Palatal and lingual extrinsic stains were reduced with selective polishing, and the reduction of edema was reduced along the gingival margin, especially in the anterior lingual and palatal regions. Patient's OHI seemed to somewhat improve compared to the first appointment. This is evident by the patient's reduction of plaque seen on the plaque index assessment. Original score was 64.2, new score was 43.7. Patient's AAP classification did not change. However, the West LA calculus code did. Patient was a 2 light with 25% interproximal calculus. For a nutritional reevaluation, patient cannot commit to not snacking throughout the day due to their occupation, so the patient now carries xylitol gum in their nursing clinical bag to chew throughout the day. Patient is working on including calcium and vitamin C in their daily intake. Patient's OHI reevaluation, they did not prioritize flossing the weeks leading up to the reevaluation appointment due to a strenuous work week and limited time and energy. Patient did, however, purchase fluoridated mouth rinse and is using that daily. Patient is now using modified Bass technique daily. Patient also noted that their halitosis is less noticeable after consistently implementing these recommendations. Patient's visible plaque was reduced from most interdental spaces when examined clinically. The correlation between stress and periodontal health was an interesting topic for me. Studies shown that correlation between stress and effects of the oral health, because the patient has a strenuous work environment, this may contribute to negative effects on the periodontium. The patient works as a surgical operating room nurse and works very long hours. Higher levels of work stress and periodontal disease are significant predictors of poor oral health. According to a Journal of Oral Medicine and Oral Surgery, stress can increase the severity of periodontal disease and decrease the effectiveness of treatments. It can also increase long-term chronic immune response and secrete interleukin levels, which has a risk factor in gingival inflammation. I thought this was really interesting because my patient does work in a constantly high stress situation at work, and there's a reason why she has chronic inflammation.